Okay, they say that there was a rabbi once who could recite the entire Talmud while standing on one foot. The challenge of presenting the theory of Melanie Klein and Otto Kernberg in 1 hour is a similar kind of challenge. I used to teach theory at the Boston Psychoanalytic Institute for several decades, and I realized after doing it for a while that theory is a cumbersome burden for any clinician to integrate. And so I had people read the theory, and then I had them present cases. And I used the cases to elaborate the theory. So I'm going to try to do that today to make this complicated set of ideas more accessible. We'll see how it goes. Okay. This is what I'm going to talk about. I'm going to talk about applying theory to our clinical understanding of personality disorder, to trace the development of internal object relationships, to compare Klein and Kernberg, to understand projective identification, and hopefully to link these theorists to the potential of all of you becoming the next generation of theorists. That's the plan. So let me talk a little bit about personality. Personality is who we are and how we seem to others. It reflects an enduring set of patterns of behavior, and it's developed in the cauldron of family life, from the interaction of constitutional givens of the child, their bodies, their sensitivities, their reactivity, their capacities, and their limitations, and the pressures of the environment, the nature of the family. Not all theorists pay attention to that, but I will try to link that in. Children are unconsciously shaped to maximize the caretaking capacities of their environment. Hold on to that. That matters because it's a two-way street in child development. Personality is egocentric. We don't notice that we have personalities. We just think we are who we are. Other people notice. It feels normal to us. We don't accurately see ourselves without help from others. We are completely dependent on other people to actually understand who we are. If our personality creates problems in others, they see it first, and sometimes they take the risk to tell us. Our unconscious effort, and I'm going to use myself as the model of this child, so forgive me if I do that. I may be talking about myself, but I'll be trying to talk theory. The unconscious effort of all of ours is to shape the external interpersonal world to fit the needs of the self. The world, sadly, resists being shaped according to our needs, and the resistance from the part of the world can create symptoms. All of us evoke in one form or another reenactments of our childhood situations. Acting out is both an effort to recreate a familiar place and an effort to get beyond it. Let me talk about how people with severe personality disorder present themselves. This is what we see. Gross fluctuations in perception, thinking, and feeling about oneself and about others. Bland acceptance of contradictory thoughts. What I feel now is real. I've always felt that way. Low tolerance for anxiety or frustration. That low tolerance leads to acting out with drugs, promiscuity, self-harm, and the things that we work with all of our working days. Difficulty in discriminating and reporting bodily sensations and emotions. And under stress, people with severe personality disorders can become psychotic. These theorists elaborate these phenomena. Gross fluctuations in perception, thinking, and feeling about oneself and about others. Bland acceptance of contradictory thoughts. I've said that already. Let's see, where am I? Oh, yes. A fear of directly asking for help. Because of this is called in the field a need-fear dilemma, a reluctance to ask for help because of the regular anticipation that help will not be coming. So you don't approach requests for help. You demonstrate the need. Unpleasant feelings escalate to panic. People have trouble learning from their feelings. There's little sense of inner continuity from past to present to future. This is what Otto Kernberg talks about in terms of identity diffusion. And I'll say more about that in a minute. Difficulty in maintaining stable relationships, in part because of trouble understanding other people, trouble using empathy. Although with some of our patients, they have a peculiar kind of empathy for the unconscious impulses of other people. They don't recognize any kind of stable defenses, but they intuit a kind of vulnerability that other people have. And I'll try to explain how that happens. There's a sense of inner emptiness because of a lack of an integrated view of themselves and other people. When they're regressed, it involves fantasies of extreme neediness, destruction, and abandonment. These fantasies quickly overwhelm these patients and can contribute to a psychotic regression. In therapy, for many of these patients, though the therapist is perceived as a separate person, the quality of the therapist is determined by the patient's internal process. They do not perceive us in a stable way because of what's going on inside of their minds. Basic outline. Freud, what these theorists have in common is that as clinicians, they paid attention to people's feelings. They theorized them in different ways. Freud theorized them as drives, libidinal drive and aggressive drives, and formulated a theory about instincts and the vicissitudes and developed a structural model of the mind, which I'm not going to talk about. Klein was a brilliant observer of infant behavior. And on the basis of her observation of infants, she began to notice the relationship to the mother. And relationship became central to her model, the beginning of a focus on relationships as a way of structuring the mind of the individual. She saw, and I'll talk about this, and elaborate a theory about the unconscious fantasy in an infant. And she elaborated envy and gratitude, which I'll describe to you. Kernberg built on Kleinian theory and developed a highly structured theory of the organization of the personality. Let me start with Klein. Klein felt and observed the existential anxiety of the infant and paid attention to the way the infant related to the breast of the mother. And she developed a set of ideas about the infant's relationship to the breast when it was being gratifying and when it was being ungratifying. And she formulated a notion about a part-object set of internal fantasies about relationships to the mother, and located her theory around affects: love, hate, fear, and desire. Love is the thing that got equated with a good relationship to the breast. Hate got equated with a bad relationship to the breast. She had a theory about how the internal world gets populated by persecutory and idealized figures. This, by the way, is a theory about the first 4 months of infancy. This took a lot of work to develop a theory like that. And she formulated how these processes underlie anxiety, guilt, and reparation. And she developed a formulation about the paranoid schizoid and the depressive positions, again, which I will elaborate in a lot of detail in the next several slides, and about envy and gratitude. Envy is associated with the paranoid position. Paranoid position involves splitting and projective identification, the good breast and the bad breast. Gratitude has to do with the depressive position where the infant can recognize that they have an impact on a parent which contains both parts. This is the shift. She thought it was a developmental shift that was accomplished by about 4 months. We now understand that the oscillation between the paranoid and depressive positions go on throughout life in all of us. But she saw it as a straightforward developmental process. She uncovered the infant's emotional world, locating conflict, love, and hate at the beginning of life. She explored the drama of inner objects and the lifelong struggle between destruction and reparation. Kernberg translated these insights into a systematic model of personality structure. He stripped away the metaphysical structure that Freud had developed and grounded object relations in observable personality organization. If we have time, I will talk about the relationship between the theories of these theorists and their own personal history, which we found a marvelous opportunity to learn about in a recent Erickson Institute presentation where Otto Kernberg and Tom Kohut talked about their childhood experiences in Germany and the impact of the trauma of Nazi occupation on the way they began to schematically develop a theory of the mind. I won't talk about that in this lecture to you, but it's profoundly interesting because it opens up the nature of the environment, the impact on the developing mind of the psychoanalyst, the nature of their observations on their clinical situation, and the theoretical extrapolations from those influences. We won't talk about it. In short, Klein explored the roots of emotional life in the existential crisis of early infancy, and Kernberg built a clinical architecture exploring how these internal worlds form enduring personality patterns, and particularly how therapy can repair them. Okay, this next slide I'm going to spend a lot of time on. When I was learning these theories, I found them very difficult to understand. So I spent a lot of time trying to abstract them and draw a schema that lays out the developmental course and touches on the different contributions of the theorists. Pay attention to what's in red. Red is the key to this chart. So S refers to a self-representation, the image of the self that's in the mind. O refers to an object representation, the representation of the person you're connected to. And plus refers to loving feelings, and minus refers to angry feelings. This chart, which I will walk you through very slowly, is a linkage between all of these theorists and gives you an outline, I hope, that will help you both go back to the theorists and read them and begin to add your own theoretical perspectives to what you're learning. Follow the bouncing blue ball. Melanie Klein imagined that the mind of the infant was filled with chaos, where the discriminations between the self and the other were impossible to grasp, where loving experiences and hating experiences were all mixed up, where there wasn't a clear boundary between the self and the other. It's a kind of chaotic confusion around an existential crisis, along with a very immature infant mind. Splitting, which you're all familiar with, because that's the nature of the work that we do, in this set of formulations has 3 stages to it. The first stage is what Melanie Klein called the paranoid position, where positive experiences were split off from negative experiences, but within those 2 cauldrons, the infant is unable to separate the self from the object. So where the self ends and the object begins is unclear in the infant's mind, and the collection of positive experiences where this boundary is blurred is split off from the collection of negative experiences. This is the paranoid position. The second stage of splitting is relevant to this, and I'll give you more texture when we get to it. When an infant is engaged with a mother around loving experiences, they can begin, this is theory, to take the risk to notice that there's a boundary between the self and the other. So boundary formation begins to take place in the constellation of loving experiences as the infant's mind matures and can begin to discriminate where they end and the mother begins. But negative experiences are still too overwhelming to manage that transition. And so the self and the object boundaries are blurred. And chaos occurs when the infant is overwhelmed by negative experiences. They don't remember that they ever had positive experience with the object that is depriving them, the object that fills them with hatred. It's overwhelming. And the third stage is when the mind develops and there's sufficient good experience, they can begin to develop a boundary within negative experiences, where they can even begin to see that even when they're angry at the mother, there's a self and there's a mother. But still, the intensity of negative experiences maintains a split. And then finally, the final stage, where the infant can begin to recognize that they are the same person who has loving experiences and angry experiences against a parent who can be good and bad, present, gratifying, and depriving. That's the schema. And if we weren't being recorded and I had to keep talking for an hour, I would ask you 1,000 questions about the schema, which you would respond to, but I have to keep talking. Jane told me for an hour, so I will keep going. I'm trying now to unpack the schema. I would have asked you to do it, but I'm going to lay it out for you. Prior to self-object differentiation, that large ball at the beginning, is a model for psychosis, where the boundaries between self and object are unclear, where loving and hating experiences are all mixed up in the infant's mind. It's a model for a way of understanding what happens in the mind of the psychotic patient. The paranoid position goes along with identity diffusion. I will spell that out to you. Splitting, envy. Let's just pause for a second about envy. I would go back to that schema, but it would take too long, so I hope you have it in your mind. If you're filled with, in a relationship with a good object, and you're an infant, and you don't know that you're good, and you're worried about being overwhelmed by negative feelings, you don't imagine that the good object is there to offer you something. And so you get a kind of suspiciousness of the other person who has goodness that's not available to you. And that suspiciousness is destructive, and you attack it. This, within this constellation, Kernberg talked about projective identification and borderline personality development. The integration of loving and hating images in that pattern that I laid out for you is the development of object constancy. That is to say, when the mother leaves and the infant is struggling with feelings of abandonment, prior to this integration of self and object representations, the infant feels abandoned. Once the infant recognizes that when their mother leaves, they're angry at the mother who has left them, but they recognize that the same mother who has left them is the mother that they had loving feelings for. So let me go back. This is here. Here, when the mother leaves, the child feels abandoned and filled with rage. Here, when the mother leaves, the child remembers that the mother is the same mother who is the one who is loving and responsive. And that is object constancy. That is to say, they don't feel abandoned. They can remember that the mother who is left is likely to come back and survive the destructive rage that the infant may feel about being abandoned. This is also called the depressive position, and Winnicott called it the stage of concern. I like Winnicott's formulation better than Klein's, because concern suggests that the infant begins to recognize that their anger at the abandoning mother is going to hurt her, and that the mother is a potentially good mother. And they begin to get worried about the impact of their aggression on someone that they love. This is a massive developmental accomplishment, and Klein called it the depressive position. Okay. The final stage is a further integration of these images into flexible psychic structures. Superego, ego ideal, develops a stable sense of self. Klein says all of this happens at 6 months. 6 months. She's probably wrong about that. But her ideas about it are extremely useful. And if you read the contemporary Kleinians, it opens up a different world that you might want to explore. Okay, so let's take this stage, for example, where the child has sorted out a boundary around their loving experiences, but still gets confused where they end up and the parent begins around the angry experiences, yeah? This is, the child feels the mother's departure or her unempathic response as abandonment, and it threatens his image of her as loving. He protects the loving image of the parent, and we see this a lot in our patients, by seeing himself as a bad child abandoned by an angry mother. The child takes on responsibility for the mother's departure. You with me? This is an aspect of what I said at the beginning, where the children are trying desperately to maximize the provision of good parents. And one of the ways they do that is by taking on responsibility for parental failure into themselves. Hence, punitive unconscious self-criticism, which some of us are burdened by. This dilemma results in profound separation anxiety, hopelessness, and a negative sense of the self. Splitting, I'm going back to that diagram. When you're involved in splitting, you can't care for the person who frustrates them. You don't hold on to the positive sense of the other person. But there is this peculiar empathy for the unconscious impulses of others. People can be internally aggressive, but manage it through a sense of mature defenses. But infants who are scrutinizing the other for their empathic failures see right through those defenses. And this is what we see in our patients when they get into us, when we take them home with us, when they have found their ways into things that we are not conscious of what we struggle with. Projection has consequences. If you project your aggression outside of yourself, it has a consequence of a loss of your own potency, your own power, your own knowledge, and an incomplete development of internalized standards. Projection has a powerful impact on the self, as does idealization. One of the impacts of idealizing other people is that you develop a kind of extreme dependency, loneliness, fear of parting, and fear of the loss of the capacity to love. Idealization is and you'll hear about this when somebody, I don't know who, talks about Freud and the development of narcissism. Idealization is a normative stage in child development, but it has implications in terms of the consequence of projecting out idealized aspects of the self. It's the same with the projection of aggression. You project out aggressive aspects of the self, you run the risk of crippling your own capacity for aggression. And then projective identification, I'm going to spend a lot of time on that because it runs through all of these theorists, these theorists. Let me start with Klein. Klein saw projective identification this way. She saw it as an intrapsychic defense, an effort on the part of the infant to manage intolerable feelings by locating them in a fantasy about the other person. It evacuates the sense of danger. We've already talked about that. It is central to the infant's early relationship with the mother's breast, and it is a precursor to empathy and internalization, once re-internalization of the projected aspects of the self get taken back. The Kleinian therapeutic approach is to interpret unconscious fantasy and its defensive function. One of the implications of early Kleinian treatment is rapid and early interpretation in the early stages of psychotherapy of in-depth unconscious processes. A quick story, I had a colleague who went to England and visited a Kleinian analyst, who I won't describe. But he walked into her office and she was smoking a cigar. And he had a reaction to what he saw. And she said to him without missing a beat, "Just what is it you think I have under this skirt?" That's a caricature of an early Kleinian interpretation. Okay. Okay. In a Kleinian analysis, the theory is that the patient projects hatred into the analyst, and the analyst interprets the patient's fear of the internal prosecution. It's an interpretation of an intrapsychic experience being projected out. This requires me for a moment to pause and talk about Bion. And the reason I have to talk about Bion is that Bion is intermediary between Klein and Kernberg. Bion was analyzed by Melanie Klein, and he took her theory and managed it in a different way. He began to think about not just an intrapsychic phenomenon, but an interpersonal phenomenon. And he described the container and the contained. You will hear that, those of you who are not familiar with Bion, you will hear that notion. The container is the mother who contains the unmanaged impulses of the child, which Bion called beta elements, and through a process manages those projections into the mother and hands it back to the infant in what he called alpha elements. This is a process of projective identification, which Bion spent a lot of time thinking about. His effort was to try to think about what the parent does in relation to the infant's powerful and unthinkable states. The effort of the mother, a so-called good mother, is to contain and transform what are unthinkable states on the part of the infant and hand them back to the infant in a form that can be symbolized. This is a notion, this is a form of thinking between minds. Projective identification is a set of communications between the mind of the mother and the mind of the infant, between the mind of the patient and the mind of the analyst. These beta elements are transmitted in this chaotic form, and he described the way the mother processed these elements as reverie. It's a very interesting word and has lots of implications going forward with other theorists. His idea was that the mother had to not reach what I have called pathological certainty about what's happening between the infant and the mother, but rather think about it, reflect about it, dream about it. How do I understand what the infant is doing in relation to me, and then hand it back in a different form? The mother returns alpha elements that the infant can reintroject and think about and begin to symbolize in language. We talk about it, language, a lot here. Transforming chaotic experiences which our patients have into language is an aspect of containment, because language is a container for unprocessed affects. And in Bionian therapy, the task is to contain and metabolize a countertransference. So that the interpretations would have some kind of form like this. You think I can't bear your anger and it terrifies you. Huh? That would be a kind of transference interpretation through a Bionian lens. Kernberg went a step further. Kernberg decided on reflection that you could really think about basic elements in the schema that I laid out for you. And the basic elements are a self-representation, an object representation, and an affect. That's the basic element that Kernberg used in his formulation of a structural theory of personality development. It combined the Kleinian notion of an intrapsychic phenomena and an interpersonal phenomena, and a shift from Kleinian notions of fantasy to a study of interaction. What happens between people? How can you break down what happens between people into its elements and study those elements? Kernberg's first paper was in the New York Academy of Science. I read that when I was in my 30s, and it was almost impossible to understand. And I spent a lot of time trying to understand it, and this is my best effort at trying to understand it, because it's extremely useful. Extremely useful. It's a little too clear, but it's as a model of a way of understanding interaction between people, it's useful clinically. The theoretical shift was from primitive defense to relational communication. He focused on projection plus behavior, induction in another person, a kind of reaction to the behavior, and an enactment through behavior. He used it as a diagnostic tool, and he developed a form of therapy, which he called transference-based therapy, which began to unpack the components of human interaction into structure. And the goal of which treatment is identity integration and his form of therapy. So this is the sequence. Melanie Klein focused on intrapsychic fantasy and a series of defensive mechanisms. Bion focused on an intersubjective process that had to do with emotional communication. Kernberg focused on structure and personality organization. Each of these theorists stood on the shoulders of the one that went before them. And this is a challenge for us, which I want to bring us to. We are all theorists, not with big capital T, but with small t. We develop theories about the nature of what's happening between us and our patients. We build on the shoulders of the theorists that have gone before us. Okay, let me give you a schematic way of thinking about the different approaches of these three different theorists when they are confronting a patient. This is very hard to do. It's much easier to do if you present process material and you can see what a Kleinian interpreter would make of this communication, what a Bionian interpreter would make of it. And you think about different ways of understanding the nature of the patient's communication. Patient says, this is very familiar, you never listen, you just sit there and judge me. And the analyst listening to that feels defensive and slightly self-critical. That's just a moment in an ongoing therapy. Melanie Klein would say, you feel I'm judging you harshly, that I'm critical and rejecting. That's actually how you feel toward yourself. And it's so painful, that set of feelings you have about yourself, that you need to see it as coming from me. That's a formulation about an infantile sense of overwhelm and the desperate need to get it outside of the self and locate it outside. The interpretation focuses on that internal process. Bion would say, it feels hard to be here with me, as if you expect to be criticized and you can't trust what I'm thinking. In fact, you feel it so strongly, as if it's almost, this criticism is almost as if it were coming from me. He focuses on how this projection is communicated and metabolized into something that the patient can begin to think about. And that's the nature of his interpretive communication to the patient. Kernberg incorporates his countertransference into his communication because he sees these basic units, a self-representation, an object representation, and an affect. So he begins to speak to his countertransference. And he says, I notice when you feel I'm judging you, I start to feel defensive and a bit critical. I feel almost pulled into that role. I wonder if you feel yourself caught up that way with others, feeling judged while the other becomes judgmental. His effort is to make a split between the critical self and the judging other conscious, to show how the projection is enacted interpersonally and structured in the personality. Now let me give you some backdrop for how this is managed in family. For a child to develop normally, one of the needs of the child is to have a strong enough maternal connection to tolerate negative interactions. This is what Winnicott referred to as the holding environment, a marvelous phrase. It relates to Bion's container and contained. It relates to all of these theorists, but it summarizes it with a kind of capacity to hold an angry infant without retaliation or withdrawal. The qualities necessary for attachment include the child's perceptual ability, the capacity to receive and seek nurturance, and to link patterns of experience. These are inborn qualities of the child and basic needs on the part of the parent. The mother needs to be able to, and this is idealized, of course, the mother needs to recognize and tolerate her own infantile needs. Having an infant, some of you may have had infants, is overwhelming. Overwhelming, because the infant doesn't communicate. It's chaotic. And the mother inevitably regresses, and her own infantile needs are mobilized and come up in relation to the child's behavior and communication. The mother needs to be able to recognize the difference between her infantile needs and the infant's infantile needs. That's not easy. It allows empathic sensitivity to the child without projection. And when we get to talking about family dynamics, you'll see how that gets played out in families. For a mother to be pathologically certain about what the child needs is bad for the child. The task for the mother is to remain open to discovering the child she has rather than the child she creates in her mind. That's a challenge for every parent. It requires all kinds of support from the external environment. No certainty. The mother needs to remain curious and interested and discover the child that she has. Okay. So if there's a poor fit, an unempathic mother, or an unresponsive child, these are both two aspects of the same dilemma. There's a history of blaming parents for the outcome of children. That was a terrible history, which we've gone far beyond. There are all kinds of components to developmental failure. If you have an unempathic mother or an unresponsive child, one of the consequences is that the child may grow up too fast in an effort to take care of the parent. Remember, the child's effort is to maximize good parenting. And so the child begins to recognize that the mother gets overwhelmed by their needs and undergoes a premature maturation to try to manage themselves by themselves and take care of the mother's anxiety. You have seen a lot of patients like this. They come across as a false self presentation. I had a patient once whose mother was schizophrenic and homeless. And she and he wandered the streets together, and he grew up taking care of this parent and developed a false self-adaptation, premature development. Took forever to get back his ability to access his own dependency needs. If there's excessive constitutional aggression on the part of the child, which is constitutional and built into the nature of the child's wiring, one of the implications is that the mother may withdraw or retaliate for the child's aggression prior to the internalization of maternal functions. And unresolved maternal conflicts can get played out in relation to the child. Okay. Now I'm going to put all of this together in my effort to lay out the best way I can get a hold of how we currently understand projective identification. This is a synthesis of everything I've just said to you to this point. These are the components that I've come to. It involves a projective aspect of some aspect of myself that I can't stand. I can't tolerate it. I can't recognize it. I try to get rid of it. I project it out. But it's not just projected out into the outside world. And it's not just an internal fantasy. I look around the world and I discover for somebody who has a hook, somebody who has as an aspect of themselves, some link to what I'm trying to get rid of in myself. We don't project onto nothing. We have a capacity to recognize the unconscious impulses of others. If we're involved in projective identification, we look for what I call the link, what Bion called a valence, some aspect of the self which fits the projection the other person is trying to get rid of. The other person has to be willing to accept the projection as an aspect of themselves. This is very tricky. I'm trying to get rid of a dystonic aspect of myself onto you. You have to be willing to be seen the way I'm trying to get rid of. I have to stay in relationship to you if I'm involved in a relationship that's dominated by projective identification. Why? Because you carry an aspect of me. In order to hold on to myself with all of my parts, I need to stay in relationship to you because you're carrying an aspect of me. My conscious experience is that you are unlike me. You are unlike me, but I have an unconscious identification with the aspect of you that resonates with the part of me that I'm trying to get rid of. You with me so far, I hope? This is very complicated. I'll try to demonstrate it. And then, when I've talked about this before, the question I've asked the group is this all fantasy? Melanie Klein thought it was all fantasy. Bion and Kernberg recognized that it was a bipersonal field. How does somebody else accept a projection I'm trying to get rid of? And how does this relationship get elaborated? The answer to that question is behavior. I behave in relation to you. I'm the projector. You're the recipient. I behave in relation to you in such a way as to elicit data for you that you are the person I need you to be. This is subtle, but it's significant. Our patients do it with each other. Our patients do it with us. They push us in ways that get us to behave in a confirming way to the kind of projection they're trying to get rid of. And when we behave and when you behave in a different way, I don't pay attention to it. This is selective inattention. This is Harry Stack Sullivan's contribution to the field. Selective inattention to disconfirming evidence coming from the other person. I behave in such a way as to get you to produce confirming data. I don't notice disconfirming data. And there is complementarity. Both sides project. The person that I'm involved in this way projects similarly into me some dystonic aspect of themselves that they're trying to manage. And both of us are pathologically certain that I'm the kind of person you think I am, and you're the kind of person I think you are. This is where pathological certainty happens. Okay, so let's say you have a man who has aggressive strivings, yeah, as an aspect of his personality, and passive longings, the wish to be taken care of. And he has a massive area of conflict. His conflict is anxiety about his passive wishes. Okay? And he meets a woman who has aggressive strivings and passive longings, but her area of conflict is her fear of her potential destructiveness. They find each other, they fall in love, and they develop a relationship based on mutual and complementary projective identification. What does it look like? You can't answer because you're not supposed to talk and I'm supposed to lecture. But I want you to have an answer in your mind. What does this couple relationship look like? I'll give you a second to think about it, and then I'll give you the answer. What it looks like is an aggressive husband and passive wife. Why? Why does that polarization show up in their behavior, in their relationship to one another? Why? Why is it stable? Let's go back to this. Think about these components. What's happening between these two people? Mr. X has a conflict about his longing, his passive wishes. Mrs. X has no conflict about that. So he manages his longing, his passive wishes, into her. She's fine with it. He's not. He's contemptuous of her passivity because he devalues the aspect of himself which he cannot bear. Okay? She has a conflict about her aggression. She's afraid of her potential destructiveness. She can't recognize aggression in herself. He has no conflict about his aggression. She takes her projection, she locates into him. She's terrified of his aggressiveness. You with me? This is mutual and complementary projective identification. And it is also, you see all of these components? Yes. It is also the dynamics of sadomasochism. If you treat a sadomasochistic couple, they don't get better. It's bewildering when you see somebody who's putting up with sadistic behavior, how stuck they are in the sadomasochistic relationship. I think one of the reasons for that kind of stuckness is a dynamic of mutual and complementary projective identification, where they meet each other's needs. Now, at the higher end of the spectrum, that's what we all do. We find complements to our personality. Let me just pause here and say, there's a spectrum of the use of projective identification from this form at the most primitive level to the highest level of projective identification. What's the highest, most mature aspect of projective identification? One way to think about it, again, I would ask the question and pause, but I can't do that. The highest level of projective identification is empathy. What is empathy? Empathy is taking an aspect of ourselves, locating it in somebody else, and checking the data to see if it fits, and trying to discover the aspect of the other person which resonates with some aspect of ourselves, which we have more conscious capacity to understand. So that spectrum goes from the healthiest level down to the most primitive level, based on the level and status of primitive internalized object relationships, which I've just marched you through. Okay? Oh, so let's say you take Mrs. X, and she comes into treatment and asks the individual therapist to treat her suffering in her sadomasochistic relationship. And over the course of an extensive psychotherapy, she becomes more able to tolerate her own aggression. What then happens? Let me just pause so you can think about it. What happens is she goes home and she takes an aggressive position in relation to her husband, putting him in a passive position and evoking his anxiety about his passivity. So he becomes impotent in the relationship. And you have an increasingly healthy wife and an increasingly symptomatic husband. That finding, that discovery from the unpacking of projective identification raises a question about what are the implications, the moral implications of treating just individuals. What are the implications of what you have done to families when you just treat individuals? and you don't hear or think about the impact on the family. Now, there was a form of family treatment that was invented by Murray Bowen at the National Institutes of Mental Health, which he modestly referred to as Bowen therapy, where he would treat individuals and send them back to their families to act as change agents in the family, using this formulation and a kind of model of treatment. Okay, I'm not going to make it to a full hour, but internal object relationships form the structure of the personality. Oh, I didn't say much about envy and gratitude, but you get it. Envy is a consequence of the paranoid schizoid position, where you get envious of the good object because you don't believe they can provide something to you. In the depressive position, gratitude recognizes that you recognize something you can get, and you recognize your concern about hurting the good object because of your aggression towards it, and you have gratitude for what the good object can provide. This is a transformation of envy and gratitude. And again, since the depressive position and the paranoid schizoid position oscillate, all of these feelings go back and forth. The integration that I described leads to healthy relationships, a stable sense of self, and a continuity of history. Containment, the capacity to contain, integrates all of the pieces that I just talked about. Just a word about theory versus theory. This is just for us. I said, don't idealize theorists. When I was in training, my director of patient care was Elvin Simrad, and he told us not to read anything. He said that our patient is our textbook, and we should develop theories about what's happening between the patient and ourselves. It's derived from clinical observation. It's derived actually from the valences of the clinician, because the valences of the clinician evoke interactions with the patient that stimulate thinking. What's happening here between the patient and me? How can I understand this in a way that allows us to abstract it? Each of us clinicians is a theorist with a small t. And we should not idealize these big-time theorists and add to the theoretical armamentarium that these people have given us our own theories. Riggs has an unusual opportunity to add systems thinking, the impact of family and organizational dynamics to psychoanalytic theory. This is already happening in the field. Couples and family treatment has found its way into the psychoanalytic literature. Field theory is a deep part of psychoanalytic theory. All of this is now happening. We have a fantastic opportunity, given the way our patients interact with one another, what they learn from one another, what we learn from the kind of structure that we provide for our patients so that they are willing to take the risks with one another, to challenge them. They developed a subgroup to think about confronting one another and what it takes to confront people. We work with family therapists. We see all of the pieces that I've just laid out with you in a three-dimensional way. We have the opportunity to add to this theoretical structure what we're learning at this institution. And I'm sorry, Jane, I'm going to stop 4 minutes before the end of the hour. So you'll have to use filler to fill in the rest of the time.